we discuss one case study. A 65-year-old male post PCA 6 months ago, LDL cholesterol is 130. And the patient comes to clinic and say, doctor, I can't climb stairs. My calves ache on atorvastatin 80 mg. This is the usual complaint of many patients on high intensity statin. But here the key factors are we should first check vitamin D levels and switch to a hydrophilic statin like rosuvastatin or pravastatin, and then introduce bempedoic acid and ezetimibe combination to reach the goal without increasing statin. We should never let muscle ache be the reason a high-risk patient remains unprotected. Coming to antiplatelets, aspirin for primary prevention, primary ASCVD prevention, guidelines and recommendations. In 2021 ESC guidelines, in patients with diabetes at high or very high risk, low dose aspirin may be considered in primary prevention in the absence of clear contraindications, that is class 2B recommendation. Whereas aspirin or other antiplatelets is not recommended in low or moderate cardiovascular risk. This is class 3 recommendation. In US Preventive Services Task Force guidelines, adults 40 to 59 years with a 10% or more 10 years ASCVD risk, this is grade C, that is aspirin may be considered. In adults 60 years or more, aspirin is not recommended for primary prevention. We should mind the gap. ACC/AHA guidelines has a cutoff of 70 years, whereas USPSTF guidelines says cutoff is 60 years. Can we give aspirin based on coronary artery calcium score? Of course we can. If coronary artery calcium score is more than 300 and low bleeding risk, aspirin should be considered. If coronary artery calcium score more than 100 and low bleeding risk, aspirin should be considered. No or mild CAC, aspirin is not considered. Coming to DAPT duration evolution. However, the old rule is 12 months DAPT for ACS and 6 months for stable CAD. Now, the new shift 2026 shift is shortening DAPT to 1 to 3 months and then dropping aspirin reduces bleeding without increasing ischemic events. In patients with high bleeding risk, 1 month of DAPT is now the standard of care for the latest generation drug-eluting stents. Monotherapy. Now we'll discuss about monotherapy. That is aspirin-lean therapy. The drop aspirin strategy. Is the aspirin is the only problem? Of course, aspirin provides modest antiplatelet effect but significant GI mucosal injury. Ticagrelor or clopidogrel monotherapy after a short DAPT burst, that is SAPT therapy, is now the new strategy. But in high complex cases, we still lean towards long DAPT despite the bleeding risk. Platelet function and genotype testing. Usually, like in patients who are on clopidogrel and with complaints, if they have recurrent stent thrombosis, then better to consider for genotype testing, and it is recommended genotype guided therapy, that is switching slow metabolizers to ticagrelor or prasugrel shows benefit. Coming to gastrointestinal protection and the PPI interaction. Many of us have the myth that omeprazole and esomeprazole reduces the efficacy of clopidogrel, but there are various trials. Finally, they show there is no increase in cardiovascular events with these agents, but a significant decrease in GI bleeds. So current recommendation is use pantoprazole or rabeprazole instead of omeprazole or esomeprazole if concerned. But we should always use a PPI in patients on DAPT with a history of GI ulcers or age more than 65. Coming to chronic kidney disease. Chronic kidney disease patients have a higher risk of both thrombosis and bleeding. Ticagrelor is preferred over clopidogrel in chronic kidney disease. However, in end-stage renal disease, clopidogrel is the safer default despite lower potency. NOVAX in 2026, beyond atrial fibrillation. NOVAX are now the preferred choice for VTE AF and increasingly in the vascular dose of peripheral artery disease. Subclinical AF. If AF duration is more than 24 hours, yes. If less than 6 minutes, NOVAX are not required. Triple therapy challenge definition. That is NOVAC plus aspirin plus P2Y12 inhibitor. Our goal is exit triple therapy as fast as possible, either ideally at discharge or on day 7. Up to day 7 triple therapy, up to 12 months dual therapy. After 12 months, drop all antiplatelets is recommended. only Novak monotherapy is recommended. Dual pathway inhibition, that is Novak with aspirin, the Compass resin. It is indicated for high-risk peripheral artery disease patients post-revascularization or stable CAD with high ischemic risk. Novaks in valvular disease. In case of mechanical valves, warfarin remains the only choice. In case of bioprosthetic valves, Novaks are now considered safe after the initial 3 months post-op window. Mitral stenosis. If it is rheumatic, warfarin is still king. If non-rheumatic, Novaks are acceptable. Coming to ACC/HA 2025 guidelines, we all know that P2Y12 inhibitor starting is class 2B recommendation in NST-ACS if the planned procedure is after 24 hours. Bridging and peri-procedure. Bridging patients with AF during interruption for a procedure increases major bleeding by 3-fold without a significant reduction in stroke. The 2026 consensus is Novaks we need not bridge, do not bridge, because their predictable onset and offset of action acts as its own bridge. Warfarin only bridge if the patient is having high ischemic risk. Protocol is that it is based on procedure risk and renal function. In low risk procedures like dental procedures, skin biopsy, cataract surgery performed at trough. Skip morning dose, perform procedure, resume next dose. In high risk procedures like major abdominal procedures, orthopedic surgery, neurosurgery, patient is having normal creatinine clearance, stop Novak 48 hours before procedure. Low creatinine clearance less than 50, stop Novak 72 hours before procedure. Coming to antiplatelets, stop P2Y12 inhibitors 5 days prior. If it is prasugrel, stop 7 days before. Continue aspirin unless the surgery is in a closed space like intracranial space. High-risk candidates for bridging. Patients with mechanical mitral valves, atrial fibrillation, CHA2DS2-VASc score 5 to 6, recent within 3 months VTE or stroke, or recent coronary stenting within 12 weeks. They are the candidates for bridging. Low or moderate risk patients, bridging is generally not required as it increases bleeding without clear benefits. Warfarin management. Stop warfarin 5 days before surgery. We should start lomocular heparin, that is Lovenox bridge, when INR falls below therapeutic range less than 2, usually 3 days prior, and stop 24 hours before surgery. DOAC management. Generally stop 1 to 2 days before surgery. Bridging is typically not required due to their short half-life. Post-op resumption. For low bleeding risk procedures, restart therapeutic anticoagulation 24 hours after. For high-risk procedures, delay 48 to 72 hours. Manage the bleed. Reversal agents. Idarucimab, immediate reversal of dabigatran. Ednexet alpha for rivaroxaban and apixaban. 4-factor prothrombin complex concentrate often used when specific agents are unavailable. Coming to fresh frozen plasma is generally ineffective for reversing Novaks due to the volume required. The art of the gray zone summary. Take-home message is lipids, go low, go early, and don't fear the combination. Antiplatelets, be aspirin lean, by P2Y12 smart. Novaks, respect the kidney and avoid unnecessary bridge. The final take-home message is guidelines at the floor, but clinical judgment, considering the patient's frailty, bleeding history, and anatomy is the ceiling. Thank you.
Thank you, Dr.